Welcome to the Uzima Health and Wellness Podcast.
What did the doctor say?
Hi.
How are you?
Hi, how are you?
Doing very well. Very nice to meet you.
Nice to meet you as well, doctor.
That's a great shirt, by the way.
Thank you. I'm going to get a custom Uzima Health and Wellness shirt made, but right now this will have to do.
Yeah, I like it. It works well.
Thank you. Thank you for taking time out of your busy schedule to
Of course.
I created Uzima Health and Wellness to do exactly some of the things that you are doing, and that is to do community outreach, to create a conversation around the social political determinants of health, to make it a word that we all can engage in. So I've been very impressed with your podcast, but let me
thank you very much.
With a very good introduction. You are an assistant professor at Yale School of Medicine and Department of Psychiatry. You are a Duke graduate. I think they call you Dookies.
That's true. That's very true.
My homework.
Yeah.
PhD from Yale in 2007. So that you really did a sprint from getting your bachelor's to your PhD. You own a lab, or you have a research lab, so you own it, where you are federally funded to research some of our challenges in substance abuse, anxiety, and depression. You've worked tirelessly in faculty in both mentoring faculty and students. You work in diversity, inclusion, and equity programs. And you've also, on top of that, been able to have time for community events and create town halls and conversations around mental health and engagement. So I guess the question is, who are you?
A little bit of all of the above.
Yeah, who are you, Dr. Addy?
Yeah, so to go all the way back to the beginning, so both of my parents grew up in Ghana, West Africa. So I'm also the son of immigrants. They immigrated here in the 70s. And that's part of the story as well, because they took advantage of opportunities they had to further their education when they came to this country and instilled that.
What part of Ghana?
They're both from Accra.
Okay, I've been there.
Oh, excellent. Excellent.
It's a wonderful picture.
Yes.
I'm
yes.
from artists in Accra.
I'm very impressed. I'm very impressed. So you spent some time there. Did you enjoy your time?
I did. I think that it was a meaningful tour. I definitely went to our castle. Forgive me, it's blanking me, probably from the excitement to see where the door of no return. And I took my 17-year-old nephew to experience that as well. So those pictures, I know that he will look back on and be like, I went there.
Yeah.
You know, it's a lifetime trip that I did.
Definitely impactful, emotional, and all those components all at once. So I have that family legacy as well. And with them coming to the States and all that they went through, taking advantage of opportunities, they instilled some of those components in me at a young age. Granted, I didn't really grasp them early on, to be completely honest. I'm sure I gave them a bit of grief, not really taking my schooling seriously at a young age. But it was a turning point where I really took ownership of that. And part of that, we moved to an area that was predominantly white because of some of the opportunities there. But that was part of my story as well. And to be honest, part of my motivation when I shifted was not wanting to be labeled as the dumb Black kid in the class, to be completely honest. So that was really, that's a key piece of my story. And it's something that I really took to heart. And of course, there were all the challenges that came along with that. You mentioned that I went to Duke University. There were challenges and doubters along the way, I would say. And you could kind of read through the lens and say, okay, well, they don't know if this Black kid can really achieve at that level. So to be honest, that's really part of what motivated me at the beginning. I know that's an experience that others have had as well. So I always like to mention that because that's part of my story in terms of how I got to Duke in the first place and invested in some of the work that I'm already doing now.
Where did you grow up?
So I grew up in Michigan primarily, but we moved around quite a bit. So we were also in Atlanta at one point, also in North Carolina. Again, with my parents' work and things like that.
When did you decide that you didn't want to be the dumb Black kid?
So it was actually in 8th grade when I basically failed a bug science project that we had. Put it off till the last minute, didn't put the work in, and just having that experience of doing so poorly and wondering, that was when I was first in that school for the first time. So really, all the pieces that come up, teenage years, wondering how people are going to look at me. And really finally internalizing all of that and realizing, okay, I'm capable of a lot more than I'm actually putting the effort into. And so that was a turning point for me.
And what was your major at Duke?
So my major at Duke was biology, but I also had a neuroscience concentration. And
Mhm.
that was through a conversation that I had with my psychology professor. I
Mhm.
asked him what major he thought. I was really curious about psychology and trying to invest in some of those components. And he actually told me not to be a psychology major,
Mhm.
which to be honest was a little bit distressing to me. I was like, what am I doing wrong here? My psychology professor is telling me not to go into this. Am I not cut out for this?
Mhm.
But I think what he saw was my love for biology.
Mhm.
And so he thought that would be a better place for me to kind of investigate some of these aspects about the processes in the brain that contribute to mental health. And it's funny because I've come full circle and I definitely pull in a lot of psychology now. I've also done an internship with psychology
Mhm.
interns during my sabbatical to learn some of those components. But yeah, initially my major was biology, focusing on the neuroscience component of things.
My question to you is, we look at a drop in, of course, Black males in college,
Hmm.
Black males entering into higher education,
Hmm.
Black males entering into clinical medicine. We are
Hmm.
at a critical low for these numbers. My question to you is, did you experience this sense of othering along the way that said, why don't I just get my degree, get a job, and call it a day? Did you experience that type of, uh, you know, discouragement, subtly or blatant along the path?
Yeah, I would say it was a mixture of both, sometimes subtly, sometimes blatantly. I was fortunate to also have those who were supportive along the way. So for your question now, I mean, I remember going to some conferences and trying to ask people who were presenting their work, trying to ask them questions. And you can tell they were just completely dismissive. They weren't taking me seriously. They were saying things like, oh, well, maybe someday you'll have something you can present here. Just like kind of how that whole you don't belong basically was the vibe that I got from those people. Fortunately, I also had people who were really supportive. So the
Mhm.
laboratory that I worked in, the principal investigator was really supportive of me, gave me opportunities to go to these conferences in the first place,
Mhm.
wanted me to stay. I actually stayed in the lab, worked for 2 years as a technician after
Mhm.
undergraduate,
Mhm.
plugged me into different programs. I got to do some programs with other minority students. So it was
Mhm.
also helpful to be with other like-minded people, other people
Mhm.
that look like me, and then also to have some professors that look like me as well. I say that really transformative part for me was in grad school when I was participating in a program called the Summer Program in Neuroscience, Ethics, and Survival. And that
Mhm.
was started by two pioneers, Dr. James Townsend and Dr. Joe Martinez, both who passed away recently, but they were deeply invested and had put years into really training other minority students to give them the skills and the equipping that they needed to succeed, and then being those examples themselves. So yeah, it's a bit of both. I had the dismissive, I had the microaggressions, but I also had strong support that really gave me the skills and the support network that I needed to be able to thrive in this endeavor.
My question, did you play any sports? Were you the athlete also at Duke?
High school, not the Duke level, so played
Okay.
basketball and ran track in high school. But that's part of the story too, because the funny thing is, I remember when I was interviewing for grad school. So
Mhm.
typically, grad programs will invite you out, and this is for all grad students who are applying to biomedical sciences, and wine
Mhm.
and dine you, try to entice you to join their program. I remember being on specific flights and telling people that I was going to schools, and they were saying, "Oh, are you getting recruited to play basketball?" It's like,
Right,
no, I'm actually looking at grad schools. There are other options for us as Black males in this
right.
country, but that's the first thing that always comes to mind. So,
Mhm. I remember watching a medical student who was over 6 feet
mhm,
become very Black male,
mhm.
being very agitated and saying, "Why do they keep asking me
Yeah.
if I played basketball?"
Mhm,
And he's like, and it's those type of subtleties that
mhm,
people don't describe as racist,
mhm,
but they're stereotypical.
mhm.
They are discouraging along the way. And we have to live that experience while trying to get a degree. And I think that, that is a a conversation that we can all have by the campfire, or as
Mhm.
well, let's say if we could drink beer, have a
Yeah.
beer summit, we would
Mhm.
do that.
Yeah.
But that's something that people need to be pointed out. They're like, well, that's not racist. That's a natural question. But do you get asked that question every day because you're over 6 feet and you're in an esteemed, or what we call a privileged white institution?
Mhm.
Why am I asked, or it's assumed that I'm here because I offer some type of physicality
Mhm.
to this university?
You're right.
And I think that's one of the things that we can subtly kind of agree needs to kind of stop
Mhm.
happening. And again, people think it's benign, but we have a cumulative experience of that, even as you said in the 8th grade. That's why I asked you, when did you have this turning point? Because young Black males sometimes fall off between 6th and 8th grade. As the data shows, that they are sometimes viewed as other, and then have to tap into these physical attributes, football, track, to get that scholarship to Stanford, to get that scholarship to Michigan or Notre Dame. They're smart, they know they're smart, but they have to tap into that kind of kinetic energy to be recognized.
Yeah. And for me, it's followed me all the way through, to be completely honest. So even when I was a faculty member, I had summer undergraduates in my lab. They're presenting their research and people are coming up to me, oh, do you have a good summer experience here? So there's still that, well, you must be a student. You can't be a professor here, because that's just not, I mean, that's not what they said, but that's what their words were implying. It just was so outside of their framework that they couldn't even grasp that it's possible this might actually be a professor and not a student.
Let me ask you, after you got your PhD, well, let's put the decision tree, MD, PhD. We say MD, manic deranged, PhD, piled higher and deeper.
Understood.
So what made you choose the PhD?
So I'm laughing because I actually had a really hard time trying to figure that out. So I was going back and forth. So I took 2 years off between undergrad and grad school because I was trying to decide, should I do the MD? Should I do the PhD? Should I try and do the MD, PhD? So I tried to get experience. I got some experience in different medical offices and things like that. And I think that tapped into my empathy and desire to help people. But I was also just really driven to really understand the science of what's happening in the brain and different mental health challenges. So eventually that's what steered me towards that direction. I did consider the MD, PhD piece. Part of it was just trying to think about, to be completely honest, how long am I going to be in school if I go that route, versus maybe being able to kind of get to the depths of what I really wanted to study earlier in my career. But a lot of that was just asking people questions, getting experience. My advisor was really good about giving me that experience as a research technician too, continuing to go to conferences, talk to people in the field. I think I really just had a desire and a drive at that point to really understand the science. And I realized there was so much that I didn't know. So I thought the PhD would be the best way to do that.
Why the curiosity in mental health? You keep repeating that as if you had some desire to understand that early on. Was there an experience that you had, or?
Yeah, so I think part of that is exposure. So my father is a psychiatrist. So when he came to the States, he actually came to the States to do his psychiatry residency through a variety of different God-ordained circumstances that opened up opportunities for him. So I think part of it was me seeing him go through that journey over time. I can't put my finger on one specific instance, but I think I was always just curious about behavior and about the brain and how those things come about. But I did have experiences as an undergraduate too. So the research lab I was in, we did a lot related to nicotine and smoking behavior, but also how people who struggle with schizophrenia have a much higher rate of smoking behavior, 80 to 90%. So I had some of these research experiences. I also spent time volunteering at a mental health hospital, so interacting with those patients on a weekly basis. So I think it was something that was just kind of emerging over time, not that I could pinpoint per se, but really just wanting to be able to have some understanding and still be able to help people on the way through the research.
That's interesting, because the two psychiatrists, Black male psychiatrists and prominent psychiatrists that I interviewed, Dr. Ron Bailey and Dr. Napoleon Higgins, again, say that there was something in their childhood that made them comfortable with the subject of psychiatry and mental illness, and also sparked their curiosity. So when they went to medical school, and Dr. Ron Bailey is the past president of the NMA, and Napoleon Higgins has been in adolescent psychiatry for over 20 years in Houston. He said his grandmother was a schizophrenic. He said, I just knew my grandmother was a little different, but that's something that made him connect with mental health patients on his rotation. So thank you for sharing that. So I think that you didn't have a taboo about this subject in your childhood. So that's very interesting. I want to know, substance abuse in the Black community is, again, that's a webinar, that's a week-long conference. So I can just pick it up from, where I grew up in inner city Houston. And I just remember in the 80s, by the time I was a junior in high school, that all the young Black males that were playing football in the street and baseball were going away.
Mm,
And they were going away because they were going to prison,
mm,
and they were entering the penal system, at 16, 17. Where is Cat Daddy? Where is Bowleg? Where are
mm,
these? I'm not making up names. These are what their
mm,
names.
mm,
And they were gone. And then as I would cycle back home, I would see them and they looked haggard and tired, and they had been in and out of the penal system. But it was the crack epidemic. That
mm,
was very real for
mm,
urban cities. And of course, that came along with that was the policy, the three strikes out. So your work in substance abuse, tell us about it, because of course it has implications for how we address drug abuse and usage in urban cities and rural communities as well.
mm. Yeah, I think I appreciate you sharing those stories as well, because that's the reality of what happened in so many areas of the country. And I think that's something that many of us have been thinking about for a while, but we still have to reconcile and reckon with on a much larger scale.
Mhm.
And as you mentioned, that's a huge topic that we could go on for a while about as well. I would say for our work, what we've really been trying to understand is what happens in the brain, both in terms of substance use, but then also when we think about substance use disorders or substance abuse, and
Mhm.
what the nuances and differences are between that casual use or something that makes it difficult for someone to continue in their life functions. So a lot of times what we're trying to do is to understand that in the brain, but also think about potential therapeutic targets that could decrease some of the craving that's associated with that if someone really is trying to get to a better place of not overusing or abusing specific substances. But then
Mhm.
all the societal implications that you mentioned as well are definitely there,
Mhm.
just in terms of how substance use is characterized or attributed to specific individuals. And I know others have written about this. Dr. Carhart has written about this recently. But the way in so many of our Black and Brown communities that is really vilified and sometimes justified by others as a way, again, of othering Black and Brown individuals in terms of how those individuals are treated. I mean, even as you were talking about your experiences in high school, I'm thinking back to my own experiences in high school.
Mhm.
Again, I went to a high school that was predominantly white, but there was still drug use, but those people weren't going to jail. So I
Mhm.
mean, that's a much larger, again, societal conversation, but it's a totally different reaction to individuals in certain statuses or in certain environments versus
Mhm.
others. And so there's still a lot that we have to do there. I mean, I think what our research is really showing is that there are so many components that are complex about this as well. Because we're also looking at the intersection between substance use and substance use disorders and anxiety disorders, or things where, we're looking specifically in animal models, but if the animals have gone through something that's stressful or traumatic, how
Mhm.
there's a higher likelihood for those uses to occur. And so that's not something that we always talk about. We just vilify, oh, why are these people doing X, Y, and Z? Instead of
Mhm.
thinking about what's the broader context that people are experiencing, how's that influencing the use, and then how are we reacting to that use in the first place as well. So I think our work is contributing to that conversation and giving us a better appreciation of what's happening in the brain. But also, we need to think about societal wise how all those things start to impinge.
Mhm.
So it's not a clear answer, but we're starting to make some progress.
So in some of your information in your video, you said the rodent brain, you
Hmm.
can use that to model what's going on
Hmm.
in the human brain. Can you explain that for an eighth grader?
Yep. Yep. So yeah, and the question that people always ask me is, well, how do you know? So we're looking at rats and mice. How do you know if they're dealing with substance use challenges, if they're anxious, or
Mhm.
if they're depressed?
Mhm.
That's a valid question. What we can do is look at behaviors in the rodents that are associated with some of those mental health challenges.
Mhm.
So, for instance, the rodents will actually take substances that people will take. And if we give them access, they're really good at titrating how much they want. They can also go through periods of abstinence. They can go through periods of withdrawal. If
Mhm.
they're in a certain environment, they'll
Mhm.
actually try and get the drug more so. So they'll show some craving type behaviors. So one of the things that we look at in particular is relapse. So thinking about animals that have been using, say, cocaine for a certain period of time, they have a period of time where they don't have access to that. If we put them back in the environment where they were used to taking that drug, and we
Mhm.
give them cues that are associated with that drug taking, they'll start to take again. So that's similar to someone, let's say someone, grew up in a certain environment, used drugs a lot in that environment. And these are from conversations I've had. They'll leave that environment, maybe go to a rehab center to
Right.
be clean. They'll come back, they're in that same environment. What we see looking at the rodents is there are a lot of processes in the brain and certain chemical messenger signals that get activated when they're in that environment that contribute to the craving and the relapse. So
Mhm.
we can look at that behavior in the animals, also look at what's happening in the brain and see if there's certain interventions or medications we can use to kind of dampen that response, keep the animals from craving and relapsing. And those same things can be applied to people as well. So it's really a direct correlation. And we can do the same thing with anxiety-related behaviors and depression-related behaviors.
So I have to ask ourselves, what is driving the addiction?
Mm-hmm.
Do you believe, or have you found that there are patients who genetically are predispositioned to be addicted? Or do you think that there is some psychiatric maladaptive behavior or some diagnoses that drives the need for addiction?
So it's a little bit of both, and then on top of that, you add in stressors that people experience, whether those are racial stressors or other traumatic experiences, and those also heighten the likelihood that people will use or get into a place of abuse as well. So it depends on what type of challenge you're talking about. Definitely within the alcohol field, there's a lot of evidence showing that there's a genetic component. So some people are much more susceptible to develop alcoholism than others due to genetics. But then that also impinges upon what environment people have grown up in, whether someone else in the house was also struggling. But it also has to do with the environment in terms of the stressors. So whether people are struggling to make ends meet, whether there's ongoing racism and trauma, all those things can heighten the likelihood that someone will struggle. So it's really a combination of all the factors. And so I think the challenge for us is knowing how to integrate and think about all those components while also trying to understand each of the individual components as well. So for us within the research laboratory, we're really focused on trying to understand the components that happen in the brain and the genetic components that can influence that, but then also some of these experiential things that can influence that as well.
And so I guess are we trying to describe the etiology of substance abuse in Black communities versus white communities is different? When we began, like for instance, we've had a before COVID in this whole drug prevention from prescription drugs campaign. I mean, it was an epidemic. You know, it was something that needed to be addressed. I mean, on down from telling clinicians, you know, that if you are overprescribing opioids, we will get you, we will identify you. Don't do this. We will trigger systems within the hospital system that will let us know if you're diverting or using drugs on a, you know, more of on a high alert, right? And so, you know, you always, as a, you know, Black clinician, I'm like, okay, now when we had the crack epidemic, you know, did we think that there was an underlying abuse of prescription drugs at that time? And, you know, because that didn't happen overnight. We're seeing the historical documents, this prescription drug abuse did not happen overnight, but that was able to be dealt with differently. And so now that we are in this, I guess maybe, I don't know what wave we're in terms of drug abuse. We've had crack. We've always had heroin since the 60s, yes. What is this? There's another drug out, I forgot, that affected rural communities very heavily. I'm blanking. Can you help me?
I'm forgetting too, unfortunately.
Amphetamines type drugs. And so we are, you know, we're in that phase now. We have prescription drugs, but what we can see is that every time it's been dealt with differently. And so my question is, have you read anything about the description of how white communities characterize their substance abuse disorders? Is it any different?
Yeah, that's a good question. So I haven't read specifically on that. I can speculate based on some of the things that I've heard so far. And I think what you're also getting at is just the huge component of cultural competence and really knowing what people's backgrounds are before they get to your office. So on the one hand, you know, we can create these systems and say, well, this is how much you can give, and we're going to monitor you and stop you once you get to this point. Or you can say, well, what's the environment that you're working in, and how can we actually help people make more improvements in those environments? So not knowing exactly how that's viewed in white necessarily versus Black communities from reading the literature, but just knowing anecdotally that there are so many important components of that. So I have a lot of colleagues who are doing this work in church communities, in Black church communities, and showing that if you meet people where they are, it's so much more effective in terms of trying to help people move forward. So it's not taking a system that may be built on other cultural frameworks or a white framework and putting that on top of the Black community, but meeting people where they are and adjusting as need be. And sometimes there's pushback. So there is, people do things like medication assisted treatment for things within opioids, and that can be really effective. But sometimes you run into cultural challenges there where people don't want to be on another medication because they think they might abuse that one as well. So it really is important to know the language of those that you're working with, where they're coming from, and to be able to move things forward. So I say there are definitely differences. It's hard for me to know exactly what those are, but I think that's part of the homework that we have to do.
That's right. And I think that as we, again, the socioeconomics of drug abuse has to also play into even the racial component as well. Because if you have just, if you're just poor, low socioeconomics, your addiction and your stressors in life, it doesn't matter what your race is. And that's
Exactly.
one of the commonalities that we can try to, again, a campfire kumbaya about. Let me ask you this. You had you tried to describe in one of your videos the difference between a habit and addiction. Because some people say, I'm not addicted. I can stop whenever I want to, and have demonstrated that ability. So can you talk about that? Can you explain that?
Yeah, that's great. A great distinction to make, because it becomes unclear in a lot of ways, as well, as you mentioned. So in a habit, we often try and describe it in terms of what's happening when you perform a specific action. So a lot of times, I like to let's use a little, like a benign kind of playful example of thinking about a vending machine. If I went to a vending machine, and I'll use my own self because I like Skittles. If I go to a vending machine, I put money in and I get those Skittles out, then I've gotten that reward. So I'm performing the action because I'm getting something out of it. If I develop a habit, I'm going to go to that vending machine and put money in regardless of whether I get Skittles or not. And I'm not going to be able to stop, because now it doesn't matter what the outcome is. It's just something that I'm going to do regardless. So when we think about that in terms of substance abuse as well, so those two pieces do actually go together. So there is a habitual drug taking that can occur regardless of what the outcome is. And that's one of the 11 components that's associated with addictive like behaviors as well. But that can extend to other areas as well. So it's not just a habit, but it's also sometimes continuing to use the substance if there are negative consequences associated with that. So whether that's physical consequences, interpersonal, psychological consequences, continuing to use that substance despite the detrimental components that are associated with that. There's also additional components like craving. So the habitual part that we think about is just one component, but in terms of addiction and abuse, it's a much larger array of behaviors that somewhat are associated with habit. But to your example, if someone is able to quit and stop, that would suggest that they haven't developed it into a habit at that point, because if they're no longer getting the good outcome, they are able to stop that behavior. But it's an important distinction to make.
I mean, because, and I know that, your words are eloquent, but I'm going to give you examples. The mom who is able to hold a job and has a weekend crack binge or weekend, heroin binge. Monday, somehow or another, they're sober, or even alcoholism. We call them functioning addicts. Okay? But they say, no, this is a habit. This is something I can stop. Then we have the stories of them where it starts out that way and then it progresses. And now you've lost the house, the mortgage is behind. Now we're getting into criminal activity. The addiction, the habit has become an addiction, and addiction has now taken over into some very dysfunctional, and the consequences are detrimental. So I think that, I know that I can point to someone, I can't say everybody, but I know that I can point to people in either my community or social close family circles that this is the reality that we've experienced with our loved ones or friends. So I think that that's important for us to understand the habit, the addiction, but the bottom line is with substance abuse, you need to get help, whatever you call it. There has to be at some point an intervention.
Right. And I think that's exactly right. And it gets on that idea of dependence as well, because it gets to the point where people feel like they can't go on without the substance. And there's lots of components that contribute to that. Sometimes because the withdrawal is so intense. And so a lot of times people are just taking to cut off that withdrawal that's so intense, but then having a hard time figuring out how to move beyond that.
Are you ever asked to explain your work outside of the neurosciences realm or the scientific realm, maybe to help either social workers or educators understand substance abuse and substance abuse disorders better?
Yeah, that definitely happens in multiple different ways. So I've done events at public libraries where I've just talked about what I'll call those sessions as the neuroscience of addiction, just as a way to start the conversation. And so sometimes we have people who will come to those who are in recovery houses and want to just learn more about it. And I always see those as both two-way conversations. That's not me coming as the quote unquote expert just to disseminate information. I am, sharing what I understand about the brain, but also listening to people's experiences as well. And those have been really enriching. I mean, a lot of those individuals will come in saying, I don't see addiction as an illness because this is something I did to myself, which on some level is true. I mean, you have to take the substance to become addicted to it in the first place. But then at the end of the conversation, they'll say, okay, now with what we've talked about, I have a better understanding of what's happening in my brain with extended use of any specific substance. And I know that that's changed my brain to a new normal in a sense. And so they have a deeper appreciation for things that they might need to change in their behaviors or ways to approach things to say that, yes, having this long-term use of this drug is actually affecting my brain, and they have to take that into account. I also have opportunities to talk to clinicians and social workers, as you mentioned, just to talk about what we've learned as neuroscientists about these components, to give them some understanding of that as well. But again, for me, I learn from all those stories that they share about their interactions with their clients and their patients. So it's definitely a two-way conversation, which I think we can have much more of in our communities, to be completely honest.
Now, you identified an antihypertensive that could potentially be effective in treating substance abuse addiction. What is the name of that antihypertensive? Yeah,
so it's called isradipine. I'll have to actually double check on the non-trade name, but it's basically something, as you mentioned, that's used for controlling blood pressure. And it blocks specific channels in the brain that also have important functions for how our brain cells function in different ways. And so, yeah, what we're finding is it seems to be very robust at decreasing the craving that's associated with drug abstinence, and may also deal with some of the anxiety that comes during those periods of abstinence as well.
So now we get to the most exciting part, and that is the launching of your Addy Hour.
Yes.
What prompted that, as if you don't have enough to do between the Addy Lab, the Addy community events, to add the Addy Hour?
Yeah, I'd say what prompted me was what I felt was really a need to be able to have these types of conversations like the one we're having right now, this really at an intersection. So a lot of what I've been able to do over the years is also talk about the intersection of mental health and faith on college campuses and in communities, as I talked about before. So when I give those talks, there's always interesting dialogues that come up. So I remember speaking at one college, and I had a student who asked a question and said, well, I understand everything you're saying. She was actually majoring in neuroscience, but she said, how do I help my family members? So she had an aunt who was struggling with, I think, depression or anxiety and wasn't getting any better. And her aunt was being told the only reason she wasn't getting better is because she wasn't praying hard enough. So for me as a person of faith, I had very mixed reactions to that comment, because I do believe in the power of faith and the power of prayer and the power of God to heal. But I'm also a neuroscientist, and I'm definitely not going to ignore all that we know about the brain. So for me, that was really challenging to hear that that person was basically missing out on all those opportunities. On the flip side, I remember teaching a class at Yale to some of our medical students and talking about what happens in the brain during periods of drug relapse. And I had a student raise their hand and said, oh, that all sounds good, but what are we supposed to do with those people who think that a higher power can help them with their substance use challenges or their mental health challenges? So now on that side, I have someone who's completely dismissive of the faith community and the power of faith to move through those things. So it's almost like I had these two different worlds that I was trying to navigate, both of which had problematic components, not intentional, but problematic components, because they were looking at things with a singular lens. So saying only through a faith approach or only through a basic science approach or pharmacology. And so it really kind of got at my passion for really making sure that these conversations were integrated, because there's so many different components of mental health. So thinking about things like we even talked about here, all the racial injustices that are happening, racism, the microaggressions, socioeconomic status, psychological components. So really, I wanted to have a conversation similar to what we started in our town halls that could be at a much larger scope. And so for me, a podcast seemed like a good way to be able to do that, to really get that message out there, and to bring in guests who could talk about some of these challenges at the intersection of mental health, faith, culture, and social justice. So we hit on some heavy topics, but in a way that I think is really refreshing and also empowering for people as well.
So recap some of your podcasts. I have
Yeah.
my notes. You recap. You tell me what the scientist took away, and I'll tell you some of my notes.
Yeah. So I would say for me as a scientist, it's been gratifying to be able to take that science out of the science bubble
Yes.
and really think about how does it integrate with everything else. So our first episode was called Wellness, Pandemics, Race, and Politics.
Yes.
So again, we were kind of hitting on everything at once, but acknowledging how microaggressions and racism can actually affect your brain. And as you mentioned before, it becomes taxing over time, the continual othering, the continual stressors that come with that, and thinking about how that can affect your mental health. But then also thinking about the power of community to come together with other like-minded individuals who have gone through that and also gain support through that. So for me, that ties back to some of the neuroscience that shows the importance of being in community, showing how community actually affects our brains and can engage certain hormones like oxytocin that are important to actually help us and can be protective for our mental health. So it's really fun to see the intersection between what I know as a scientist with what I know about the challenges of racism, with what I know about the challenges of politics. We also get into things about, all the political tensions that are coming up, just the ways that people have been trying to deal with all those, and really saying that we need to think about all those components, not deny the challenges that come with those things, but learning how to deal with all those stressors and the anxiety to walk through them to get to a better place of wholeness.
Well, let me just say some of the recaps for me. The first one, the term post-traumatic stress disorder. The intersection, I'm an anesthesiologist, the intersection that we have sometimes with post-traumatic stress disorder, depression, and suicide is at the ECT room, okay? And so one of the things that I was wanting more was the statement that we do have the psychiatrist who was able to administer electroconvulsive therapy for patients who have really become debilitated, incapacitated, unable to do basic needs for themselves. If they've become, that mind-body separation could make them that incapacitated that they need electroconvulsive therapy. And that's a big discussion, and a big jump in therapy. We also, with the psychiatrists have, this whole stepwise approach to antidepressants, and then trying to decide if there's a mood disorder on top of these things, as well as if there's any type of maladaptive behavior. So we have this type of, psychiatrist, psychologist, and then you as a neuroscience helping us understand basically clinically driven and proven evidence-based medicine so that we can approach the patient not just out of witchcraftery, but more out of a scientific approach. I think that, so this whole, that kept coming up in your podcast. So I appreciate hearing both the politician and the scientist say those post-traumatic stress disorders. I mean, your politician, your political scientist use the term a lot of this type of collective post-traumatic stress disorder, which also are experienced on during the riots. We never saw it before. We never felt it before. I think we all were aghast as a nation during that time. We also, and you almost have to think about the police officers that were out there who now are at risk of post-traumatic stress disorder. And you of all, scientists and physicians, we know that these type of events, for someone who's experienced cumulative events, or even this one traumatic event, can put them at risk for substance abuse. Would you?
I would definitely agree. And the triggering is so high. I mean, that's one of the things that's so clear in the research. Once you've been through those stressors, it makes it that much more likely that, that you're going to be at risk.
And we also agree there's not enough psychotherapists around, and that this could also make them suffer in silence. With one of your guests, Dr. Alfie, said, this thing of and Doug Middleton. We actually taken the title doctor. He's Dr. Middleton.
He's Dr. Middleton now.
so that basically you feel alone, that you're suffering in silence. And then I love the fact that you have sports men, Doug Middleton and Alan Houston. I remember him in my youth, that name, on your podcast, because it's important for us to, again, reach out across other disciplines and the athletic world. And Alan Houston used the word pain. And I really appreciated him, invoking that, the experience of pain, isolation during COVID is real. And how he, managed that. And he compared that to an injury, and that this could be short term. And then you talked about the issue of suicide and suicidality, and that this is I think it was Middleton who talked about his friend who died by suicide, and that this was a short-term, a long-term fix to a short-term problem, but that people are in pain, and the goal, of course, is to try to get out of that pain.
Exactly.
And then lastly, which I thought was, and I could listen to the last podcast over and over, was the inheritance of trauma. I mean, like you said, that could have been hours upon hours of discussion. And I trained at Grady as well. So I know the experience. There's a Kiesler, who spoke about the Grady Project. And so I did rape crisis there. I did my internship there. And he's right that we could never tease out the substance abuse without a history of trauma in those patients, particularly in the 80s and the 90s. And so I think that this may explain, when we talk about drug addiction in the community, we have to kind of think about the social, political, the structural racism, socioeconomics. I mean, it's just such a big onion to peel back. But the reality is we don't have enough people in the field of psychiatry, mental health counselors, and we have to rely on the church. That goes back to the conversation about the church. So my question is, have you tried to create a curriculum for whereby spiritual-based counseling can be more scientific-based, and then people can go to where they feel comfortable, but they are getting more of a scientific structural approach to the therapy?
Yeah, that's a great question. I haven't been involved in it directly, but part of what we're trying to do on the podcast is make sure those resources are known. So I do have a colleague at Duke University, Dr. Warren Kinghorn, who's both a theologian and a psychiatrist. So unique in a sense that he's on both sides. And so he's been able to contribute to some of these. One is a mental health resources for faith leaders for exactly that purpose, to be able to do that. And he's also has close colleagues that he works with, particularly a group of individuals in Harlem who started the Hope Center a few years ago. Yes, the Hope Center. And they're actually going to be guests on the next podcast. So they're going to talk about exactly that, really bringing the science and the psychotherapy and those components into the community through a church setting to be able to make sure that people have access to those resources. Another great project is the Imani Project that was started by colleagues at Yale with the same type of thing, actually doing substance use recovery work in church settings and partnering between mental health professionals and pastors in those settings. So I think everything you're saying is exactly right. And it's really making sure that people feel equipped. Because in a lot of ways, I think the church is the first line of defense in a lot of ways. People will go to their pastors as that first intervention. And so I have friends who are pastors who say sometimes they feel like they're expected to know everything and to do everything, which isn't fair to them. I mean, they are appointed and anointed in those roles, but they also need access to some of those other resources because they can't do it all on their own. So it's on a lot of us who are neuroscientists, who are clinicians, who are mental health experts, to be able to partner with those individuals to make sure that we make those resources available.
I think that the theologian, psychiatrist, doctor, tell me his name again, please. Dr.
Warren Kinghorn.
I think that his role is vital in helping faith-based communities understand that medication is not a sign of weakness. It's not a sign of weakness. And I do as a anesthesiologist, you know, I deal with drugs all the time.
Mhm.
And yes, you know, can you just give me a little bit of that medicine? You know, I'm like, well, if you don't want this surgery, I'll give you as much as you need to get you through this safely.
Mhm.
So, you know, so there's this fear of medications, period.
Mhm.
You know?
Mhm.
But yes, we do need to understand it's not a sign of weakness,
Mhm.
and that these are the, you know, scientifically tried treatment protocols.
Mhm.
I want to say that I'm going to end it, that there has been documented with the Joshua Gordon, he's the director of the National Institute of Mental Health.
Mhm.
They did a symposium, and we are seeing an increase in psychiatric disorders before COVID, after COVID diagnoses.
Mhm.
And this is a real phenomenon. We don't know how many people will now go from a you know, healthy, well-adjusted, hopeful life,
Mhm.
have COVID, may not have had any type of need for hospitalization, but then on the other side of that, become diagnosed with anxiety, depression,
Mhm.
ability to basically re-enter the workforce.
Mhm.
I think that one of your other guests noted that there was a lack of research right now. That might have been Dr. Outler. It's particularly with her work in teenagers,
Mhm.
that we don't know, because the pandemic is still going on,
Mhm.
what the research will show us about the suffering of particularly our youth, young adults who make up the workforce. And so we also are seeing, capturing the fact that suicide is on the rise.
Mhm.
And so with that, we definitely need to, I guess, put all boots on the ground, as we say,
Yeah.
and get creative with our strategies for helping
Mhm.
communities.
Mhm.
And that would include the Addy Hour.
Oh, I
So,
appreciate that. And that's our
absolutely.
goal, definitely our goal, to make sure that we can bring those pieces of the conversation to light and have those resources there so that people can. I think some of these conversations, a lot of us have been thinking about it, but not really talking about it
Right.
or hearing it talked about in the public space.
Mhm.
So then we're kind of all left to our own conclusions without getting input from each other as a community. So I'm hopeful that this will also be a community endeavor in a lot of ways.
Well, I will continue to follow. I've subscribed to the Addy Hour. I thought
Thank
I've
you
met
very much.
so many researchers. I'm happy to bring light to their work. I think
Mhm.
it's very difficult to sometimes get outside of our institutional walls and
Mhm.
just be comfortable with having a conversation,
Mhm.
and bringing communities together to say, yes, we can talk about this, and there's no dumb question,
Mhm.
and every perspective needs to be considered. But it's all about making strategies, would you say?
Yes, I would definitely say that. And we can all get those strategies as we work together.
Okay, I'll talk to you all day. So I'll be listening to the Addy Hour. I hope that I can reach out to you again. I hope that I can consider
Yes,
you a friend
I
and an
definitely
ally in
welcome
this
that.
cause. And I want to thank you too for being more than what the paper says about you. You're genuine. You devoted your life to God, and you've accepted your mission and purpose. And I think that's from our ancestry as a people. And so I thank you for embracing that. I really, it's a lot. So I appreciate it.
Oh, I deeply appreciate that. And I appreciate all the work that you've been doing in so many important ways as well. It's a pleasure for me to be able to jump in and contribute, even just being here today.
Thank you so much, Dr. Addy. Okay. And I'll
Thank
talk to
you.
you soon. Bye-bye.
All right. Take care.
Bye-bye.
Hi, Uzima family. If you like what you're seeing and what you're hearing, subscribe to our channel. Hit the bell icon below to be notified of our recent videos. What the doctor say?